Welcome. In this segment, we'll be talking about another type of study design called the cross-sectional study. This is yet another type of observational study design. These are the learning objectives for this segment on cross-sectional studies. They are to list the basic characteristics and be able to explain the cross-sectional study design, and also to learn to identify the advantages and disadvantages of the cross-sectional study design. Cross-sectional studies fall into the observational study design type. They are one of the 4 types of observational study designs we are covering in our course. Like cohort studies, cross-sectional studies conceptually begin with a population base within which the occurrence of disease or health outcome, and sometimes the simultaneous occurrence of the exposure, will be studied. For example, the population could be all individuals currently living in Harare, Ethiopia, or it could be all children ages 5 to 6 currently attending kindergarten in Seattle, Washington, or it could be all taxi drivers currently working in Beijing, China. A key aspect of a cross-sectional study is that the exposure and the outcome are assessed at the same point in time within the specified study population. If you conducted a cross-sectional study in 1990, you would first define your study population. For example, all adolescents in high schools in the city of Rio de Janeiro, Brazil. You would then survey all the high school students at school and ask them about their exposures to traffic pollution. For example, how close they live to heavily used roads. At the same time, you would also ask them if they currently had asthma or asthma-like symptoms. In this example, you obtain the information about both their exposure, traffic-related air pollution, and their health outcome, asthma, at one point in time. This is in contrast to both the cohort study, in which you start with defining the population, measuring the exposure, and then ascertain the disease at a later date. In this diagram, the investigators start in 1970, measure exposure, and then assess the health outcome in 2007. The cross-sectional study design is also different from the case-control design. As you might remember, the case-control design starts with selected cases and controls and then looks back at exposures in the past. In this diagram, the investigators start in 2005, selected cases and controls, and looked back in the past at exposures in 1970. Here is another diagram of the cross-sectional study design. You start with defining your source population or population base. Then you define your study population. And next, you sample study participants from that study population. Among the study participants, you assess both exposure and disease or health outcome status at the same point in time. An easy way to think of a cross-sectional study design is as a snapshot of an exposure and or health outcome at one point in time. Here's an example. Among all individuals living in the United States, what is the prevalence of type 1 diabetes? Let's now apply the cross-sectional study design to the topic of distracted driving by looking at a study done by Vera Lopez et al. In 2013. Using a mobile phone for either talking or texting while driving a car can lead to traffic accidents. The Vera Lopez study took place in 2011 and 2012 in Mexico. Mexico, like many other countries, has a public health problem with regards to high rates of deaths from traffic accidents. Several municipalities have passed laws restricting mobile phone use by drivers. Researchers selected 3 cities in Mexico. Their goal was to measure the prevalence of talking and texting on mobile phones among drivers in the 3 cities. A sample of 3% of all intersections with functioning traffic lights in all 3 cities was randomly selected. With a systematic sampling methodology, 7,940 drivers and their vehicles were observed during 2011 to 2012. The overall prevalence of mobile phone use while driving was 10.8%. Now we will discuss the numerator and denominator of the prevalence measure used in cross-sectional studies. Cross-sectional studies are often used to describe the occurrence of a health outcome or exposure in the population. The measure used to describe this occurrence is prevalence. For the numerator, you include all existing cases of the health outcome or disease in a population group, i.e. prevalent cases, while for the denominator, you include all existing persons in the study population, or among study participants, including both prevalent cases and non-cases. For example, Among adults 50 and older living in Dallas, Texas, what is the prevalence of high blood pressure? The numerator would be all people 50 years or older with existing high blood pressure. The denominator would be all people 50 and older living in Dallas, Texas. There are several ways in which cross-sectional studies may be used. Some cross-sectional studies characterize the prevalence of a health outcome or disease in a specified population in a defined period of time, i.e., prevalence. Other cross-sectional studies obtain data on the prevalence of exposure and the health outcome or disease for the purpose of examining the association of these two variables. For example, is smoking prevalence among adolescents related to smoking prevalence of parents? Now let's look at how to conduct a cross-sectional study. First, a cross-sectional study begins with a defined study population, from which data on the presence or absence of the health outcome in individuals are gathered. Second, the researcher ascertains the prevalence proportion of the health outcome in the study population. The prevalence odds ratio and prevalence ratio are commonly used measures of association when data are obtained from cross-sectional studies. Some cross-sectional studies ascertain just the prevalence of a health outcome, while other cross-sectional studies ascertain the prevalence proportion of a health outcome among the exposed and unexposed persons. For example, in this diagram, the prevalence proportion for both exposed is A over N1 and non-exposed is C over N0. For example, let's think about the prevalence of type 1 diabetes in undergraduates. That would be A divided by N. The prevalence of type 1 diabetes in female undergrads is A divided by N1, and the prevalence in male undergrads is C over N0. In comparing females and males, one sex is considered exposed if there is some evidence from the literature of a difference in type 1 diabetes between sexes. Here's the example with smoking. You may want to answer the question, what is the proportion of student smokers who have a parent who smokes? On this slide, we will calculate a prevalence proportion. The exposure in this example is at having at least one parent who smokes, and the outcome is middle school student who smokes. P1 equals A divided by N1. In this example, it is 50 divided by 220, or 22.7%. The interpretation is 22.7% of student smokers have a parent who also smokes. It is important to recall from a previous lecture that under steady-state conditions, prevalence equals rate times average duration of the disease or health outcome. Note that there are some limitations of cross-sectional studies. For instance, the prevalence is influenced by the rate and duration of the health outcome. For example, persons who survive longer with a health outcome or disease will be more likely to be counted in the numerator of a prevalence proportion. Short-term survivors are not as likely to be counted, as they are, by definition, around for a shorter time. Sometimes there can be issues with interpreting cross-sectional studies. Antecedent consequence bias affects cross-sectional studies and case control studies, but not cohort studies. In cohort studies, persons are selected for study because they are exposed or non-exposed while they are still at risk and thus disease-free. For example, if you were investigating diet and arthritis, in a cohort study, we obtain data on diet at baseline before any of the study subjects have evidence of arthritis. In a cross-sectional study, we ascertain dietary patterns at the same time as we obtain data on the presence or absence of arthritis. Thus, you cannot be sure that the exposure preceded the disease, as they are both ascertained at the same time. So what are cross-sectional studies used for? Cross-sectional studies can be used for different purposes. They are widely used to estimate the occurrence of risk factors or health outcomes in the population. For example, a study to look at the prevalence of elevated blood lead in toddlers or the prevalence of asthma in children. National examples of cross-sectional studies of great importance are the decennial census, the National Health and Nutrition Survey, or NHANES, or the prevalence of HIV-positive antibodies in military recruits. Opinion polls and political polls are basically cross-sectional studies. Surveillance of changes in smoking habits or of other behavioral risk factors are sequential cross-sectional studies. Similarly, surveillance of long-lasting diseases such as AIDS are cross-sectional. Other cross-sectional studies obtain data on the prevalence of exposure and the health outcome for the purpose of comparing or looking at the relationship among these two variables. One example we discussed in this segment was the proportion of student smokers who had a parent who smokes. In this example, we calculated the prevalence of the exposure, parents who smoke, and the prevalence of the health outcome, the proportion of student smokers. This concludes the segment on the cross-sectional study design. Remember, the most important thing to remember about a cross-sectional study design is that it's a cut or a snapshot at one point in time in which you measure both the exposure and the health outcome at the same time.